Well, today I have Professor Stephen Duckett for the interview to look at issues of measuring quality and safety or quality of healthcare services in Australia. And Stephen is the Director of Health Programs at Grantham Institute and also the founding Professor of Health Science at Trobe University.
Health Policy, that's right.
Yeah. Well, thank you very much for your time. And I prepared 4 questions to ask you. And the first one is we recently had the SHAPE Symposium, and the colleagues raised concerns of having difficulties in defining good care and measuring it. So if you use an emergency department as an example, are there any routine data that you can see that we're collecting can allow the demonstration of service performance and also allow benchmarking and comparison across the state and also the nation?
So you can use routine data in lots of different ways, and in part the answer to your question depends on how you define quality. So if I use the emergency department as an example, you can measure waiting times, for example. You can measure how where patients go after they've been to an emergency department. You can also measure whether the emergency department picked up the problem properly. If a person comes back to the hospital 24 hours later, there's a sign of poor quality there as well. So there are lots of ways you can use the data, but I think there's the most widespread use of routine data is actually for inpatient care, and again it's now well established that you can use the routine data to measure quality of care. For example, we collect information on every patient that's discharged. We collect whether the diagnoses were present on admission or not, and so you can measure what diagnoses arose during the course of an admission. For example, were there bed sores, pressure ulcers that came about during the course of the admission. So these data are already collected in the routine data set and should be used as part of measuring and monitoring quality of care.
So what did you say should be used? Does that mean that actually have not been used for comparison and benchmarking across?
Well, in some cases it's difficult to use it for benchmarking.
Yeah.
Across hospitals. So, for example, some conditions that are recorded in the routine data, such as operating on the wrong leg, for example, I think is in the routine data, but certainly reopening a patient because of sponges left in the wound are in the routine data, and those so-called never events, you don't need to risk adjust. You don't need to adjust them because they should never occur. Many of the other, you might need to make risk adjustment for the mix of patients or whatever for some of the other conditions. And so that makes it a bit harder to benchmark. That's not to say you shouldn't provide the information to the hospitals. You shouldn't provide the information. I think you should provide the information publicly to the public so they can see the sorts of adverse events, conditions that occur in public hospital, in all hospitals actually. And so I think we should be using the data and we should be providing it, and hospitals should learn from their own experience and track themselves over time, and in that way you don't have to do so much risk adjustment because you've essentially got the same patient cohort.
So I think the health service accreditation should be making this process much more transparent? Or?
Yes, so for example there's a standard in the national standards, for example, about infection control. And my view is what we should be doing is looking at the routine data. We actually collect cases of hospital-acquired infection, and we should actually be using that to say, well, this hospital has a relatively higher rate of hospital-acquired infection. What about having more frequent accreditation visits to that hospital to assess against the standard? Is that one of the reasons why they've got higher rates of hospital-acquired infection?
Okay, so they use different procedure to investigate and identify issues rather than everyone follow the same thing.
Yes. Then there's now a classification of hospital-acquired diagnoses, so-called CHADICs, which groups all of these hospital diagnoses that occurred during the course of the admission into a classification, so you can actually look at the pattern of hospital-acquired diagnoses, adverse events, in your hospital, compare it to other hospitals, and work out where that means you should go in terms of investigating where things are going wrong.
So data collection and analysing data could be really time-consuming and expensive as well. So our discussion with students found we have concern of over-measuring, and we tend to collect a large amount of data that have limited benefits to decision-making. Do you have any comment on this?
I don't agree with that at all.
No.
I think we're at risk of under-measuring. We're not using the routine data to the extent we can. We've got lots of data there. We should be using it. It's easy to analyse. What we're talking about is frequency distributions. It's not sophisticated analytics. What is difficult is working out what to do about it. What are the interventions you need to do? So the data analytic task is trivial relative to the organisational change, the intellectual analysis that you have to do to work out what needs to be done.
So the statement I made was wrong. Is we've been collecting larger number of data, large amount of data, but we haven't been best used them.
That's exactly right. We've got the data there. We just need to use it better.
Thanks for your comments on that. And then my next questions. There's often confusion between service performance and service outcomes. And under the current activity-based funding models, the public hospitals understand the outputs are measured. And also our experience with hospitals, they also collect some perceived performance outcomes data, such as through staff satisfaction survey and patient satisfaction survey. So do you think that hospitals do collect some performance and performance outcomes data objectively? And have they been using them?
Yeah, well, I think there's more that needs to be done. In the United Kingdom, in England, for example, they collect what are called patient-reported outcome measures, where the patient actually says, you said I was going to have this operation on this hip replacement, for example. The purpose of having the hip replacement was to reduce my pain. And so the patients are asked, for example, what was your pain like before you had the operation? What was your pain like after the operation? And so they can compare whether your pain was reduced and whether the average amount of pain reduced at your hospital was better or worse than at some other hospital. So actually beginning to focus on the patient's experience is where we need to go, and we need to be incorporating that into our practice and into the governance arrangements for the health system.
So will we be incorporated into the funding model? Or?
Well, I'm not sure whether I'd start with doing that. I'd in the first instance start with actually collecting it and publishing it so the patients can see what they should expect and can expect in different hospitals.
So are these happening in the Victorian public hospitals?
Not at the moment, but it happens in England, and I think it should be happening here.
Okay. So my next question is, in your opinion, is routine data collected by public hospitals good enough to monitor quality and safety service provision and to help us make decisions what are the efforts and initiatives we require in order to improve the quality and safety?
So you've got to be very careful about using the routine data in this sense. What we want to encourage, or what is a good hospital, is not necessarily a hospital which has but partly is a hospital with a lower rate of adverse events. But what you particularly want to encourage is if an adverse event occurs, that you start to look at it and examine it and learn from it. And similarly, if there's a high rate of adverse events, you want to learn from that. What is it? Why did it happen this way? So what you want to encourage is an openness, a just and trusting culture, that you use the data to investigate. You don't want to use the data to punish. So the whole point of this is using the data to open up, to investigate, to work out where to ask the questions, not the data won't give you the answers. And so my view is the data are good enough to ask the questions, but they never will be good enough to answer those questions.
So you mentioned open culture and non-blame culture. I believe this is the policy in Victoria for more than 10 years now. So do you think these is still a barriers to best use the data to inform decision making?
Well, I can't comment on that because I haven't actually looked at the cultures, but I think there certainly is. I think the example at Djerriwarrh Health Service is one where the culture was not a good one, which didn't allow openness and transparency. Whether Djerriwarrh, there's some debate about whether Djerriwarrh is symptomatic or whether it's a one-off. I suspect that it's more systematic than a once-off.
Thank you. You recently published a report called Perils of Place, Identify Hotspots of Health Inequalities, and you used the data from hospital across 10 years periods and identify those hotspots of inequality in the hospital system. So can we assume that our hospitals have been collecting data that can inform actual performance, allow comparison benchmark?
So these data we were looking at potentially preventable hospitalisations, so-called ambulatory care sensitive conditions, and as you said, we used 10 years of data to do that. And yes, we obviously believe that the data is meaningful, the data are meaningful, and we can use it to start action on addressing unnecessary hospitalisations.
So have you identified any issues from the data you collected through this process that you would like to address for the hospital information collection system?
What we found, importantly what we found, was that a postcode which has a high rate of potentially preventable hospitalisations 1 year has only a 50% chance of having a high rate the next year. And so what was important is not you just use 1 year of data, and we said you've got to use at least 3 to 4 years data in the stuff we published. We used 10 years of data. So you've got to be careful that you use the data properly. But apart from that, the data are good enough for those sorts of purposes.
Good. So just to end the interview, from your many years' experience of using data to inform decisions, what are the most challenging things when it comes to data collection in our health system, and what's the most challenging things in using them to inform decision of how our health system is working and what improvements are required?
I think probably my answer to that question is the most challenging thing is actually using the data. If the data aren't used, no one will bother about the collection and so on. Once you start using the data, people will say, oh, these data are wrong, it doesn't have this, that, or that. But it's only after you use it that people then say, oh, the data are wrong, let's correct it. Yeah. And once that happens, it's right for the next time. So it's really important to start using the data, and I think that's the most important challenge. We also, related to that, is that often we're not as evidence-based in our policy making as we ought to be. So I think it's again really important that we're upfront about what the data are showing and that we learn from that and we compare our performance. When I think we often, there was a survey done recently which looked at hospital board perceptions of their performance in monitoring quality, and almost everyone who answered that survey, I think 99% of people who answered the survey said their hospital is above average in its quality performance. Now, of course, that's totally impossible, but it shows that they're not using the data to monitor what's going on, and that's the problem.
So I think that's what the comments you made have implication to designing our higher educational programs, how to incorporate those elements into our training to make sure.
Yes, well, it's not just teaching people statistics, what is a mean and so on. It's also teaching them how to use the data, what they can see in the data, what are examples of what they can use. The other thing that I find really distressing is that very often people look at a set of tables and they only look at the mean. They don't look at the distribution. They don't look at how much variability is, and in particular they don't look at whether it's, the variability is caused by the fact that newly arrived migrants, for example, have a different pattern of care from people who have been here a long time and so on. Indigenous people got different levels of different patterns of treatment. And so it's looking behind the simple statistics, look at the whole data, which I think is important.
This is when we did the research project 5-6 years ago in Victoria and looking at how managers use evidence to inform the decision making, and we found critically appraise the data information they see is one of the biggest challenge to them. Not only they're not getting the right training from the bachelor or master degree training, also it's not highlighted in the organisation of its importance. I think I completely agree with what you just said. Well, thank you very much for your time. It's a joy talking with you today.
Thank you very much.